Okay, so our next case is actually a patient from Dr. Swoboda's clinic as well. She was a 69-year-old African-American female. She is a Jehovah's Witness, echo of 1. As far as her medical history, diabetes, CKD, she had some iron deficiency anemia in the past, but also long-standing anemia since 2015, had multiple upper and lower scopes, which were all negative, and subsequently developed thrombocytosis in the October of 2024. Similarly to our previous patient, she has no history of prior chemo, radiation, no exposures, no personal or family history of hematological malignancies. However, her daughter also had iron deficiency anemia. So the patient actually came to Tampa General Hospital back in January of 2025 and was seen by another service. At that time, a bone marrow biopsy was recommended. However, the patient declined. Therefore, she was started on weekly Procrit and received 3 doses. By March, she was referred to our outpatient clinic, and she was seen as an initial consultation when she really complained about profound fatigue and dyspnea on exertion. At that time, her labs revealed mild leukopenia with a total white blood count of 3.28, ANC was 410, her hemoglobin was down to 5.6, she did have some macrocytosis, and her platelet count was elevated at 524. EPO level was also obtained. It didn't come back right away, but after a few days, we got the result of 201. She did undergo bone marrow biopsy, which revealed hypercellular marrow with megaloblastoid erythroid precursor and atypical megakaryocytes. There were more than 50% of ring sideroblasts, only 1% of blasts, and moderate reticulum fibrosis. Based on these results and the presence of thrombocytosis, she was diagnosed with the MDS-MPN overlap with ring sideroblasts and thrombocytosis. Based on these results and the fact that she's been kind of in a challenging situation where she is a Jehovah's Witness, is unable to receive blood products, we have decided to start her on luspatercept at a higher dose, just like it is studies in the Maxilla study currently. So at 1.75 milligrams per kilogram every 3 weeks. In addition to that, since we were trying to get her hemoglobin levels up rather quickly because she was so symptomatic from her anemia, we also added darbepoetin every 3 weeks. So after 1 dose of each, she was seen in a clinic again, and we have seen a great rise in her hemoglobin. It went up to 7.9 within that time period. And the overall plan for the patient was to keep her on darbo until her hemoglobin has stabilized, and then continue luspatercept, however, with decreased dosing. Now I'll let the mic to Dr. Alvitar so he can talk to us about the genomic findings.
So you already heard that patient had ring sideroblast, and for sure we detected the SF3B1 mutation, and there were additional mutations in TET2 and KMT2C. There were no chromosomal abnormalities and no BOT cell clonalities. So these are the findings in this patient. So as you can really see, the SF3B1 detected at high level, 41, and the additional mutations are, the low-grade kind of MDS. They don't change the diagnosis. It is MDS with ring sideroblast. We cannot call it MDS-MBN with ring sideroblast because that's usually reserved when you have mutations with JAK2, as you can really see in this example. This is a different patient, or JAK2, CALR, or MBN, or MBL genes. So you need really to see mutation in one of these genes to call it MDS-MBN-RS, according to the WHO classification, despite this patient had high white cell count. Now, not all patients with ring sideroblast are the same. So this is, for example, a patient with no question has the SF3B1 mutation, but has bi-allelic mutations in TP53. So this is extremely aggressive disease. But more importantly, I want to point out in this particular patient, actually as a different as example, this mutation BRBF8, this gene is similar to SF3B1 genes. It is a splicing gene. And approximately, it's recently reported, it is approximately 50% of patients with this mutations, with a mutation in this genes, will have ring sideroblasts. So in case you have a patient with ring sideroblasts without the SF3B1, it could be because of a mutation in this particular genes, as you can really see it here. Now, again, actually this patient mutation, it was classic mutations in amino acid 700, as you can see here. Most of the mutations in this gene, they are in this particular, the 700, but it can be in different locations. Now, there is one mutation at amino acid 592 has been reported to be associated with significantly more aggressive MDS and actually without ring sideroblasts. So not all mutations are the same. And again, this has really emphasized the importance of testing for the whole gene, mutation of the whole genes. We always, like really to test for whole gene, not for hot spots. If you test for hot spots, you will be missing a lot of mutations, and because yes, I mean there are common mutations, but the mutation could happen anywhere in the genes, and this is significantly more aggressive disease, as you can really see here. I'm going to stop here. Dr. Swoboda.
So tomorrow morning, we're going to have a great session talking about the COMMANDS trial. But in this particular example, we have also noticed that the patient neutrophil count was not as high as we would have expected. And I think that's where the MEDALIST phase 3 clinical trial comes to place, because based on this data, we now know that not only the hemoglobin levels can be affected, but also the neutrophil count and the platelet count.